So hello everybody, my name's Adam Watts. I'm an elbow surgeon from Wrightington Hospital in the northwest of the UK. And today, in conjunction with neoligaments, we're going to go through a technique for reconstructing the lateral ligament complex. The indications for lateral ligament reconstruction are situations where the patient has a painful subluxation of the radial head, typically associated with a condition called posterolateral rotatory instability of the elbow. That's where there's a deficient lateral ligament complex, often extending into the common extensor origin. It's important to understand the anatomy of the lateral ligament, which has several elements to it. You have the radial collateral ligament, which goes from the lateral epicondyle to the annular ligament, which travels around the radial head from the supinator crest on the lateral side. There's the lateral ulnar collateral ligament, which goes from the lateral epicondyle to the supinator crest, and again blends with the fibers of the annular ligament. And there's an accessory lateral ulnar collateral ligament as well, which is really just a continuation of this sheet of fibers. What we're increasingly recognizing is that there is another element to the lateral ligament complex, and that's the posterolateral ligament, what we've termed the Osborne-Cottrell ligament, which arises from this part of the posterior capitellum, and that also contributes to posterior stability of the radial head. Patients with a lateral ligament injury will present with elbow stiffness, with pain or locking symptoms of the elbow. Frank dislocation is relatively rare and is normally associated with more severe ligamentous injury to the elbow. So the tools that we require for a reconstruction are 3.5 drill, number 2 synthetic suture on a short stubby needle. So I'd normally use something like an Orth cord, which is strong because we can incorporate that into our repair. And then a 2.0 prolene on a straight needle, which is used for passing sutures. And then to do our reconstruction, we're going to use a synthetic graft and near ligament Infinity-Lock graft. And the indication for the use of the synthetic graft is patients who have hypermobility, so a Beighton score of 5 or above, patients who don't have a donor graft, so they don't have a palmaris longus, although some surgeons will use a strip of triceps instead, and patients in whom you're undertaking a revision reconstruction. It's important to have the option for a synthetic graft as well when considering a reconstruction for both medial and lateral ligaments. In most cases that's not necessary, but when you have a chronic dislocation or a chronic recurrent simple dislocation of the elbow, then it may be necessary to reconstruct both medial and lateral ligaments, and the use of a synthetic graft in that situation is extremely helpful. It avoids taking multiple autografts from the patient. In terms of our positioning of our bone tunnels, there are going to be humeral and there are going to be ulnar bone tunnels. The humeral bone tunnel is often talked about as being at the center of the circle that makes up the capitellum. In reality, the center point of the lateral ligament complex is slightly posterior to that. It's about 2 millimeters posterior to that. And in fact, if you palpate in the patient, you'll actually feel that just as on the medial side that they have a protuberance, the medial epicondyle, on the lateral condyle there is a protuberance, the lateral epicondyle, and the ligaments arise from the inferior surface and anterior surface of that protuberance. So when you palpate that, you know that your ligament and therefore your bone tunnel needs to arise from this position. You also, when drilling that humeral bone tunnel, you need to think about the position of the graft. So if you want your graft to sit in this position, to arise from this position, you actually want to bring your hole just a little bit more proximal and posterior, because the graft will always sit at the inferior point of your drill hole. So you don't center your drill hole in exactly where you want your graft to be. You put your drill hole just slightly proximal so that the graft will then sit exactly where you want it. We'll then create a drill hole coming from posteriorly and proximally to connect to our docking hole, and then we'll create a second anterior hole, so these are going to connect as a Y through the distal humerus over the lateral condyle. On the ulnar side, we want to create a tunnel, and the positioning of the drill holes is important here. The first drill hole wants to be where the lateral ulnar collateral ligament inserts, and the lateral ulnar collateral ligament inserts at the head-neck junction of the radial head and just onto the supinator crest. So we're going to place our drill hole in this position, and we're going to aim towards where we, in our heads, have planned to put our secondary hole. And the secondary hole wants to be quite posterior, so it wants to be about 1 centimetre dorsal and 1 centimetre proximal on the ulnar. And the reason for that is that we want to create a posterior band. We're going to have an anterior band, which is reconstructing the lateral ulnar collateral ligament, and a posterior band, which is reconstructing the posterior lateral ligament, the Osborne-Cottrell ligament. There are techniques that we also use to create a spring at the front of the elbow, and I'll show you that in the cadaveric demonstration.